Bismillah ar-Rahman ar-Rahim. Thank you very much, Yasir, for organizing that, and thank you very much for the organizing committee. Today, we're going to start our first lecture of addiction, and it's my pleasure, actually, to introduce Dr. Rama, which I believe is the first time also we meet together, and I think it's the first time she's giving a lecture to the Sudanese residents. So Dr. Ram is a consultant psychiatrist working in NAFOR in Qatar. So please, Dr. Rama, if you can please introduce yourself, just give a brief CV about yourself, about your training and your current job, and then you can start the lecture. You have 50 minutes, and then after that, we'll open the floor for discussion for another 10 minutes. Okay. You can start, Dr. Rama. Thank you.
السلام عليكم يا شباب كلكم. دكتور عبد العظيم, thank you for introducing me, giving me the chance to give something here. أنا اسمي Rama Kamal. I've done my my studies in terms في مصر as doctor, and then I did my training as addiction medicine specialist, and then as a psychiatrist in the Netherlands. Got my PhD there, and worked for quite a long time in addiction care and mental health in the Netherlands with different jobs. A long CV to talk about now, but I usually love training and have been giving trainings and lecturing in Maastricht University, also for the residency and for the addiction, for the psychiatrists who actually do addiction psychiatry afterwards. Again, I came to Qatar several years ago, 3 now. Then الناس جو بالكوج مع Corona لقطر, so 3 years of half of them were two of them were Corona. I work now as senior consultant addiction psychiatry, leading the lady services in NOFOR. My background as addiction psychiatrist is more in acute psychiatry, and I did a lot. So, and I'm also director of research in NOFOR. So, شايفين? Can you see it?
Yeah, we can see it. Yeah, you can do it a slideshow.
Yes, I'll do that. So, my main issue or reason for doing this kind of discussion with Dr. Abdul Azim, there are some parts of issues of neurobiology of addiction in which the residents might benefit of knowing it. And again, this talk is not meant to translate it to practical work in this talk, but it's just to give a concept of how addiction impact the brain and the complexity of that, and to give you also, as a residents, kind of an ammunition to think about the different substances and how they work in the brain. And mind, كل حاجة قبل بقول لياسر إنه today was one of my longest days, وبدينا نكبر، فبعد وقت معين كده بالليل التركيز بيبقى ما زي ما هو يعني. من سنة 97 كده بقى I'll think and I'll speak about addiction more towards the brain disease concept. بدأ مع Alan Lasher, who's really one of the pioneers to speak about that and to write about it. And إذا أنتم متابعين يعني بتقروا كثير references هتلقوا إنه في قش من الوقت ذاك of articles mainly coming from the NIDA. قبلها من Charles O'Brien and then Nora Volkoff, يعني بكون كتبت لها زي 200 article كده about the brain, how does it look, and how is the addicted brain impacted, and all the neurobiology and things towards that. So I'll never beat that, but I'll try to give whatever we can of information. The simplicity of the slides is just meant to give a picture of how it is. It's complexer than what I'm going to present, but generally talking about substance, from substance to use to addiction, we have stages in which we go through, or the patient or the addicted person go through, starting from introduction to the drug with all the reward perspective in which we're going to discuss. Repeating that gets the patient in a transient phase, which is going towards conditioning, tolerance, experiencing withdrawal of the substances. That's also the phase where change in the brain starts to take place, talking between the normal hemostasis that the brain has to changing into allostasis and another level of normality. And then we go to the craving and relapse perspective where real changes in the brain takes place. So if we talk about reward, I think the main thing that will be discussed here is mainly that we're talking about, we'll be talking about certain sites in the brain, starting from the ventricular tegmental area, the nucleus accumbens, and the prefrontal cortex. That will be the main areas that we'll be speaking about. I'm not passing any, neglecting the other parts because it's complexer than that. But then these are the main areas in the brain that usually comes in the discussion, and then we'll speak about the amygdala and other places. Reward is more complex than what we can say. There's a lot of neurotransmitters who's impacted in the context. The reward for everything, not only for drugs, mainly lies within the dopamine theory, which puts the dopamine in the center of the reward, especially for drugs if we're going forward. So knowing that every drug with an addiction potential بيزيد لنا الدوبامين either عن طريق إنه يأثر عليه indirectly على الدوبامين neurons في ventricular tegmental area, أو which always projects to the nucleus accumbens, or directly, and then we'll see further in the slides how that happens. Usually drug of abuse can do that also through effect on the different molecular targets موجودين عندنا, and impacting that through their pharmacological effects. And again, not only dopamine, there are several other neurotransmitters which are implicated. So when we, and again زي ما قلت أنا نايدة تعبوا في الإيميجينج ستاديز حقتهم الكثيرة اللي عملوها, they're usually, what I'm trying to say, they tried the imaging studies بتاعتهم ولكن حاجات يعني specifically in the reward system of addicted brains, إنه بكون فيها decrease لل activation of the reward regions. يعني sensitivity بتاعتها للnormal non-drug rewards بتكون قالة, وده بخلي عادة معظم either due to the use of drug ولا أصلا naturally from their يعني basic neurobiological concept that they have decreased capacity to be excited بالحاجات الطبيعية, food, sex, other things, normal pleasures, to a level that is enough for them to feel the happiness they have. وممكن the addicted يعني patients who has addiction, and mainly معظمكم psychiatrists, you've seen that, and that there are big vulnerability, for example, for the patients who has ADHD. mainly because they have the same component of decrease in dopamine, decrease in reward in the brain. There's a decreased expression of the dopamine receptor D2, and the release of dopamine in the ventral dorsal striatum. Now decrease the activity to the negative reinforcers. نحن عادة بنتكلم إنه every behavior عنده impact إنه there's a positive reinforcer, negative reinforcer, and even that في الaddiction process إنه كان استخدمتها and the context was that طلعت برا تشكلت مثلا بسبب الدروكس دي. I should think it's not a good thing to do, but due to the reduced reactivity in the prefrontal regions اللي هي أصلا the control regions, a negative reinforcement بتكون kind of diminished. But beside the dopamine, في influencers ثانيين غير يعني في let's say in that perspective, when we are talking about other reward systems like serotonin, which is really one of the important non-dopaminergic influencers for reward, because in itself, it also impacts the release of glutamate and neuropeptides, which are mainly an important thing for happy feeling. We بنستخدم SSRIs for the help and pumping people. We have the endogenous opioid modulators اللي هم موجودين في الجسم. endogenous opioids موجودة طبيعي, which actually also modulate the mesolimbic dopamine system, and helping pleasure, values, rewards, and also helping in integrating guiding the decision making and the executive goals of behavior. One of the things that we know about the mu opioid receptors إنه ما بس هي target للهيروين والopioid drugs, لكنها برضو ممكن is part also of rewarding feelings في non-opioid drugs. الناس اللي بيستخدموا alcohol and cocaine and nicotine, there's an impact in the mu opioid receptors, and it's also one of the reasons لما نيجي نشتغل معاهم for craving, helping them to يعني decrease the craving. بنفكر في naltrexone, sorry, and we use that also as a help. Works on mu and works in kappa, but it works better. And then the endogenous cannabinoids also contribute to the reinforcing of kind of inhibition of the negative effect states اللي بيحسها البني آدم. Sorry, شكل الحاجات نطت بطريقة بايخة كده. I'm so sorry. I just wanted to add to the concept of the endogenous cannabinoids إنهم they're really important in that perspective to know more about them, and hopefully this will give you a hint to read more about them, because it's kind of a normal dimmer switch في البرين حقنا. بتساعد brain dynamics إنه ما يبقى overwhelmed by extreme excitement or even the inhibitory effects it's very كان potent modulator لبعض النيوروترانسميترز الثانية زي GABA and dopamine in other areas. Is a bigger system that is functional. بيحصل إنه مع الاستخدام بتلقى إنه في extremities بتحصل عند humans لو يا excitation شديد يا إما inhibition also on the other side. We'll come back to it, but it's something to put in mind. And sometimes بتلاقي في بعض الحالات قدام بنجي الحاجة اللي قاعد نقولها في استخدام الكانابيس, it might be very destructive, but it could be very helpful for some of our patients. يعني زي patients اللي عندهم for example schizophrenia بنعمل كده وبنقول ما شايفينهم هم بيستخدموه if it's within the limits and works towards decreasing decreasing the zombie feeling that they have usually with medication. Focus in the literature usually comes back to the two pathways of dopamine and serotonin. And again, the function of these words, and both of them is an important thing to come back to because of that. Dr. Abdulazim is going to tell something about medication in addiction the coming period. ما عارفة إذا نبغى اليوم. Again, contextually, we're going to come and speak about medication in addiction. So most of our medication in addiction falls within this parameter between the two pathways, serotonin and dopamine. One of them, reward, compulsion, everything and pleasure, and the other one is more towards memory and cognitions and feeling happy in both perspectives. One of the important what do you call it? مفاهيم مشاكل ما عارفة يسموها شنو بالضبط بالعربي within the addiction إنه how that goes to a conditioning perspective. What we usually see is that the repetition and increase في إنك تستخدم drugs and to give that stimulation every time بيخلق في البرين what we call drug addictive. Hello? Okay. A drug predictive cue اللي هو في إنه again any encounter with cues دي بتعمل في النهاية triggering this start increasing the dopamine في nucleus accumbens, and mostly it directs the attention to the drug cue and stimulates motivation عشان الواحد addict to go and use drugs. The motivational drive towards drugs بيبدأ even قبل ما يستخدم الدرج نفسه بيكون related to the predictive cues. يعني البيشنت اللي بيجي ماشي ومع التكرار he used always to whatever it is to sit in a certain room with a certain color ومعاه نوع معين من انواع البيره عنده شكل قزازه معينه جا مر برا شاف زول في التيشيرت بتاعه في نفس الباتل دي the cue itself can make him think and trigger the compulsion or but مع ال consumption itself الstimuli ده بيزيد وبيبقى consolidated by the pharmacological effects نفسها and بتزيد ال conditioning learning أو بيبقى a cycle of okay this mean that and then the relapse and the drug taking cycle which repeats itself. The motivation to take a drug in addiction is driven by usually 3 cues if we relate that also to dopamine. One اتكلمنا عنه حسي اللي هو predictive cues اللي بتعرض لها أو بتكون اتبنت بالconditioning. Transient dopamine stimulation or increase in that stimulation through D1 and the weak signaling from D2. And again, it's kind of an imbalance موجود في البرين between the receptors. We know that dopamine عنده from 1 to 5. The receptors, 1 is 2 is usually we hear about it. The psychiatrists متعودين على إنه يتكلموا عن D2 كتير لأنه is implicated في حاجات كتير زي post traumatic stress, schizophrenia. So there it is one of the let's say how do you call it important receptors that comes back usually when we're discussing psychiatric problems. Where am I? Yeah. لما يكون في weak signaling ل D2 and there is no insufficient encounter ل D1 بتحصل مشكلة في إنه بيحصل في kind of a facilitation للcompulsive intake للدrugs itself. So that balancing then D1 and D2. D1 usually is upregulated in the addicted brain and D2 is downregulated. Both of them reinforce the values بتاعت الدرج إنها مهمة and the perspective of the predictive cues وبيخلوا الكاباسيتي بتاعت العيان والادكت to control his behavior أقل كتير يعني is more compulsive in the drug consumption. It's all electric perspectives and a lot of dimensions here, but I just picked up the most important issues. Again, it's simple. I didn't take all ما كل المحاور. But one of the important things in which we have to keep in mind إنه the enhanced sensitivity للcues دي could help you in the clinician also to see the addiction severity and it's usually a predictor of worse clinical outcomes. And the more sensitive the person to his condition drug predictive cues, the harder the treatment is to change this modules of thinking and positive negative reinforcement mechanisms. Another part of it is the part that which is very important, the part of the memory and emotion. وأعذروني أنا لأنه إذا 50 دقيقة للموضوع this kind of a little bit, but I'll try my best to go through it. There are projections normally from the dopamine neurons in the ventricular ventral tegmental area to the amygdala and hippocampus, and we know that that is the center which actually mediate emotion and memory association. Also, the important part of the dynamic here is the prefrontal cortex, which usually mediate salience attribution, and that's controls. And that's actually an understanding of sensory impact or impulses which comes in the human brain link this sensory impulses. شفت لي whatever شفت الكنبة دي the color بتاعها is related to a nice emotion of having fun. It gets printed in my memory, and whenever that cue comes back, then the saliency attribution, which is there, makes me think about it, but I have control to think, what am I going to do with that? And that control comes mainly from the prefrontal cortex. All of these sides, the amygdala, hippocampus, the prefrontal, they participate in the reinforcing and conditioning for chronic drug consumption, and we'll explain how and why. There is also for the emotion, again, glutamate and GABA, they play a role in that, and they are their co-release modulates also the release of dopamine and the presence of other neurotransmitters, which also part in that dynamic, which is the acetylcholine. Another part which is different and affected in the brain due to the use of substances is actually metabolism within the areas itself. And we know that the metabolism of the brain dictates a lot of reactions and behavior, if we're not mistaken. In the stratum, and again, we're coming back to D2 receptors, are associated with baseline metabolism activity. It's actually sometimes seen as markers in the brain function. And then the downregulation اللي احنا بنشوفه عادة بيكون related للديكريز metabolism في الاكتيفيتي either في orbital frontal cortex or for in the anterior singular cortex أو في prefrontal. ده في العادة بيعمل enhance لل motivation value of unfortunately drug among addicted وبالتالي a result بتاعتها إنه okay there's more compulsion and impulse in using because the control is less and is lost or at least is compromised. An important part which is not shouldn't be forgotten or neglected, the development of the brain itself. If the brain is exposed to use of drug or in young age, that also impact the dependency or the intensity of the addiction or exposure للدرug إذا كان في البطن ولا في لما تكون in adolescence periods where the brain is in development. Impact really the circuits which is really necessary for self-regulation. بنشوف إنه patients اللي بيبدوا using drugs in young age, the outcome بتاعته بتكون poorer mainly because the impulsivity is hard to control and the variability is larger than other users. Because the drug of abuse itself affects the brain performance and cognitive ability again. And it delays the maturity of the networks الموجودة في prefrontal cortex. So it increases definitely the risky behavior of them. And one of the most risky behaviors are drug taking. Another thing which, and I'm not going to go in the discussion, epigenetics, whatever, the modulation of the brain due to the environment or change in genetic perspective, like in the simplicity of that brain development is usually influenced, yes, by genetic factors, which also reacts to the environmental exposures. So adverse social environment problems like early childhood trauma or events which are really impacting the brain can lead to impacting the maturity. And I think في الليكشر اللي حضرناه الأولى عن التروما there was also mention of impact on dopamine in that perspective. And here بنفس الطريقة an increase of the stress hormones contributes to the impulsivity, and part of it also there. Social stress usually is linked to higher impulsivity and أنا ما أظني حقدر أعمل exercises, so I'll try to إنه أفوته. لكن simplicity of the exercises when you look at something like this يعني كلنا as humans not addicted. أنا hands الناس اللي بيشربوا سجاير واللي بيسفوا تمباك, so I'll say not addicted. When you see something like this, danger, you have an emotional impact in which goes through two perspectives. Normally, you see the chart, there's an emotional stimuli thing through your thalamus, hypothalamus, sensually, and there are two roads to go. Either we go through, I don't know, I can't point it, but you have the low road, that's the quick impact of the sensory thing that we've seen to the amygdala and having an emotional response of running away or not thinking about how the shark would impact you. But there is also the high, what we call the high road, the lower sensory cortex road, in which as human هتشوف الشارك دي بتقول oh, this is a blue shark. Actually, the best thing to do is to stay standing, because إذا أنت ما عملت حاجة هتعدي من جنبك من غير ما تأذيك.
راما ممكن اقاطعك دقيقه واحده بس. لما تبعدي شويه من الكمبيوتر دائما الصوت بيكون بعيد، فخليكي شويه قريبه عشان الصوت يكون واضح.
Okay, thank you. I'll try my best, hopefully. كده كويس؟
كويس شديد كويس شديد.
Okay, thank you. So if you put that in an addict, and an example of few slides about alcohol, somebody you've seen the glass of beer, the emotional stimulus and the sensory thalamus will react. These patients do not use the high road, so it is the low road for them, directly to the amygdala and an emotional response, and mostly their emotional response is pick that beer and drink it. That's actually the exact thing which was worked out by Volkoff 2004, low impaired response inhibition and salience attribution. Why can't addict just quit? Simply said, because the dynamics is different. We spoke about now, you see something, your saliency works, it starts there. And then you tell you have the connection towards your memory, use that. And then you have two commands. واحد بيقول please go towards that beer, but there is also a link to your prefrontal cortex, which is the control center, which is big enough to speak to the underlying office and say, no, this is a no-go, you're not doing it. Vice versa in the addicted brain, and I'm sorry I cannot point anything, just follow with me. Saliency is really dominant. And what addicts remember from that perspective is only the positive reinforcement part. I've been happy, it is okay, it's good, relieved, all of the things that are related to the positive reinforcement. The link between the memory and salience keep the addict in that loop. And then the command goes to both, yes, go please pick that beer bottle, and tells the control, oh yeah, there is a problem, but because the control it's not that powerful, with all the undermining things that we spoke about, the command goes to the drive, and which is usually the orbital part, in which doesn't have any control, and unfortunately the reaction is yes, go. Reflecting what we spoke now to brain areas, control is the prefrontal cortex, and then the anterior cingulate. We're speaking about the saliency, which usually happens within the nucleus accumbens. Our control is the orbitofrontal cortex, and then yes, the memory in the amygdala and the hippocampus, and you see the relation, what we spoke now. It is complex, there is a lot of centers who are involved, but this is for the simplicity of explanation. I'm not going to go through this. Hopefully there's a lot of residents hearing. This is actually a table to help you look at which brain structure is involved in which stage of the addiction process, which is يعني ما بيمشي بالمسطرة, but it is you can see the most, again, dopamine is taking the lead, but there are a lot of other neurotransmitters which is involved in every phase. So taking, for example, if we are we want to help somebody against their impulsivity, and we know that they are in that level still of managing this inhibition is not yet deep in their craving processes. You might think about using medication which can work on the neurotransmitters, like take help of glutamate, increase that for these patients, try to help them in that perspective, increase their GABA somehow, have a balance of glutamate, and there's a lot of medication which can help there, but do understand that this is the dynamics which happens with the patient. So I'm not going to go through it, but just use it as a helpful tool to guide you where to think and which neurotransmitters are mostly impacted. Again, a full slide, but the main issue here is to know that in both the ventricular ventral tegmental area and in the nucleus accumbens, the specific substances works through initiating increase or impact on dopamine, either directly or indirectly. If you look at this, you can see what we're saying. For example, the opioids work, they do not impact the dopamine directly, but they work through impacting GABA in the ventral tegmental area, the neurons there. So that also has impact on dopamine, and then you go further from that perspective. So all, either directly or indirectly, every substance has their own way of doing it. So usually substances which work directly on dopamine, either the axons or the neuron itself, leads to more gush of the dopamine. So for example, stimulants like amphetamine or meth, they impact the neuron or the axons of the dopamine neuron directly. So that means that their gush of dopamine will be higher than other substances and quicker. So knowing that type of dynamics can help you to assess what are you seeing here. In a high dopamine, we know that from the psychiatric perspective, that means impact on the cognition of the patients. You can see patients having hallucinations or whatever presentation of a psychotic dimension, if it's that high. In a medium thing, you see patients hyperactive or not able to sleep, and the whole context in that area. I'll take it from one simple thing, like if you look at alcohol addiction, in all the stages, if we're talking about the normality, you have, if you're non-alcoholic, your GABA and glutamate are in balance. When you start to use it, and in intoxication, you see that that balance goes out of it. So you have, while you're intoxicated, GABA takes the hand. While you are in withdrawal, glutamate takes the hand, and you see this disturbances or whatever the dysregulation and the symptoms that the patients usually show. So again, it is just to explain where you can focus with every substance. Benzodiazepines work differently, but again, it impacts GABA, it impacts glutamate in a different way. That will help you because there is also a direct influence in the ventricular tegmental area, and that's why the benzos work quicker than alcohol in their addiction perspective and in the impact also on dopamine release. So that people like the benzos more than alcohol. and their detox is harder. So if you look at cocaine does another concept. It actually blocks the reuptake of dopamine, which makes the dopamine also increases in the synapse and has effect. And decreasing the reuptake means also high intensity of effect, quick, and quick also adaptation or decrease in the plasticity. And that means in the long, in a shorter periods, there will be change in the receptor level and regulation between upregulation and downregulation of the different dopamine receptors. One of the important things that we need to know is that with cocaine in specific, it is kind of an important report marker that for stimulant naive individuals, they could actually have impact on their receptors even from the first stimuli, from the first dose, or from starting for short periods. And because there is also impact on the metabolism in the prefrontal cortex, and with their impact directly on the neuron itself, but also indirectly, they decrease. They have also concurrent glutamate effect. Amphetamine does actually both. It decreases same as the cocaine. It just does something in the reuptake and blocks that, but it also increases the dopamine release because it has impact on the axons of the dopamine neuron, but also because of the amphetamine impact on the noradrenaline, which is actually also one of the precursors of dopamine, or is one of the important precursors of dopamine. So you have a triple impact. That's why patients who use meth or amphetamine shows very quickly higher doses of dopamine, and you see that in their reactions. If you look at nicotine, so everything, you have everything. We underestimate how nicotine works in our brain, but it is actually one of the, I call it still drugs, that impacts almost every neurotransmitter in our brain, and that's why also addiction to nicotine is so hard to stop, and the relapse is easy to happen. One of the so sorry, Shabab. One of the important parts of what we usually address in addiction is tolerance to the drug. Tolerance of the drug happens actually on the level of the cell due to upregulation of the CMB, and that is one of the important parts, but it has been seen in the research or studies in the last period that that upregulation can be reversed. You see it during withdrawal, but it adjusts itself along the way when the activity of using drug is stopped or discontinued. Just to wrap it up, I think the most important things, and it's not my last slide, but I'll just try to go quickly through it. We're trying to say that addiction is a chronic relapsing disease. The brain is triggered by the repetition of exposure. There are multi-factors which makes the brain vulnerable. We have genetic development, social exposures, the circuit's capacity to respond to reward and motivation which are not drug related in the addicted brain, is actually decreased sensitivity of the emotion stress بيكون زايد وعندنا مشكلة في الكباسيتي حقتهم to self-regulate. The compulsive drugs seeking رغم من إنه عارفين إنه this could cause a lot of harm is due to the inability يعني إنه to control the urges despite يعني desire or motivation to quit, but it's not an easy concept. يعني الموضوع مش moral, so we need to work on that part. And there are a lot of changes in the brain which is responsible for the maladaptive behavior اللي احنا بنشوفه, and it stays for months and mostly for years after discontinuation. ما بنحب نقول له once an addict is always an addict. No, but it takes a long time to go back from the allostasis that is created to the hemostasis status, and which would be beneficial for this patient. These are two tables, are busy tables, but I think you could benefit from it as a resident, so maybe a psychiatrist, knowing that how the mechanism that the substance work. And I'll take one example of for example, the alcohol. We're saying that, opioids is the first one. Morphine impact, it decreases GABA, which leads to increase in dopamine. And again, stimulation is always, impacting or increasing the striatal dopamine release. So if you know the mechanism, you can think of, okay, what do I really need to do in treatment perspective? Dopamine is increased, GABA is decreased, which type of medication can work with these patients, especially in craving, not just in maintenance, but for the long run, helping them to work with it. I can go through every one of it, but I think hope that you understood what I went and meant with it. It's really a very good table to work with, and it's it has been helpful. You can find all of the drugs there, the classic hallucinogens, inhalants, nicotine. And again, the message is understand how the drug works, but the impact on it is a complex issue that we are addressing here, and we're hoping إنها تكون 1 2 3 نقدر نحلها. But that means that when the patient comes also with comorbidity, you have to think twice about which medication can I give here. If we look like the stimulants, we know, for example, that they give a very high gush and rush of dopamine. So patients who are under influence of stimulants, be very careful to give them their ADH medication, for example, for several days, help them to calm down for a day or two, and then start again with everything, because that might put them in the risk of going into an extreme psychosis in which you don't need. Other patients, like whatever the GHB or the alcohol patients, you have to be careful of. It takes them a very long time to dip their dopamine level and the glutamate disturbances there. So that means that if you're giving them medication, you have to be careful in the period that you're giving that. It's never a day or two, as we learn, and a week, and the patient is off your withdrawal. No, they have longer periods. They need longer periods to be stable and be able to work along without help of medication. I don't know إذا الناس بتقدر تفتح مايكاتها ولا لأ, but I would hope that one of the residents would answer this. It's a case where we're talking about a male. I just put it. I didn't see that in one. I'm so sorry. It was supposed to be think about it. So maybe you can discuss why did I put the differential diagnosis, stimulants abuse or anabolic steroids? And I hope that one of the residents have the courage to answer. Or Dr. Abdulazim, name somebody.
Guys, anyone? Volunteers? Or shall I name?
Assalamu alaikum. Yes,
Assalam,
I
go ahead,
can
yeah.
proceed.
Yeah, please.
Assalamu alaikum, Dr. Rama,
Right.
Dr. Hussein here. Going with stimulant abuse because he's male, young, he doesn't seem to have any other mental conditions or physical conditions. He's talkative and he came with paranoia.
Okay, go
auditory
back.
hallucination.
Just one thing, I didn't tell you he doesn't have a physical. I said it wasn't
Yeah.
possible. So I
Okay.
didn't have any physical examination. I'll try to explain it. Patient is
Okay.
20. He came, he was talkative, paranoid, had auditory hallucinations, restless. He rejected physical examination. I don't have any information. And he presented alone. And I'm so sorry, differential diagnosis was there, but help me in the think pattern. Why did we choose it? You started
Okay.
very good.
Okay, so we chose the stimulants as a first differential. من الكيس هنا عندنا first he's a young male. دي حاجات available. He came talkative and paranoid with auditory أو paranoid auditory hallucination, which is very common. اللي هم بيجوا ببارانويا بالسوداني بيقولوا على مبرنب. It's a very common feature of psychostimulants. He is restless.
What does it indicate? Which neurotransmitters would you think? And أنا عارفاك هتقول dopamine, but what else?
طيب dopamine. والله I was going to say dopamine because of the auditory hallucination.
No, dopamine is right, but you have more. Dopamine is right. What would you expect? He has dopamine and he's so excited. He's so moving along. He's talking a lot. He's paranoid, but would be also in a higher level beside the dopamine.
Acetylcholine also can cause can participate in hallucination.
Yes. So he has both in high levels. He's moving a lot. And again, yes, it could be that, but it could also be anabolic steroids because it gives also the same picture of increased dopamine, GABA B actually receptor agonist. So all of the excitatory neurotransmitters will be kind of dancing around. So that's why he's moving a lot. He's restless. He doesn't have any, he cannot rest. And then, would this patient be schizophrenic?
We cannot, we don't have enough data, sufficient data to say schizophrenia. He presented with auditory hallucination, but due to his young age, I think, and because he came to the hospital, I think. And هم عادة السكيزوفرينيك الكرونيك سكيزوفرينيك أو الويل سكيزوفرينيك بيكون السيتويشن بتاعهم يعني somebody will bring them or they will find them in the street or something like this. Like this man came to the hospital, first presentation, I suppose. He is young and he is male and he look muscular. Okay. So muscularity means that he is taking good care of himself. Yani he's not self-neglect. So we cannot, or I will not put schizophrenia as my top differential here.
Yeah, he might be. He's too young for that, I think, from perspective. But again, never exclude anything unless you are sure of it. But at least your first 3 days would be more in the perspective of look at what is happening to him, look towards drug use than other things. He might be, you never know. He might also be schizophrenic. He might also be manic at this stage. You never know. But the first thing, and Dr. Abdulazim can add to that if he has any perspective on it, that you need to observe the first days to see what is left over. If there is a schizophrenic underlying process, you'll see it after several days. If it's the substance, you'll see a differentiation in the picture in which can help you to pin it and clean up your diagnosis.
Mhm.
Thank you.
Excuse me,
Galeg.
I just want to add things. If
You might-
we look for the age, regarding the age and the onset, schizophrenia also can be implicated in this case, because the common age for schizophrenia would be 19 to 25 in male. And it's not necessary to be self-neglect. Maybe it's the beginning of schizophrenia. According to ICD-10, it's 1 month enough to diagnose schizophrenia.
Again, that's why I put it as a question mark. Schizophrenia, affective storiness, you never know. But it is, in this point, the first thing that we like always to say, please give space, especially with young people, before you pin it and you start giving this patient an antipsychotic, which might put him in a dangerous place than what he's supposed to be. It can also lead to massive and quick neuroleptic syndrome. So especially if he's using amphetamines in high doses. So it's smarter to wait, observe, give something which will calm this patient, mainly in a benzodiazepines perspective, because it will decrease it will help at least decreasing the glutamate, bringing the level of decreasing the dopamine to some extent, but it will help the patient and his brain to rest for some time, and you can observe after that and make your decisions. Thank you for listening. Hope that your night will be nice, and I'm so sorry I went through very rough material so quick, and my apologies for the non-concentration and not bringing a lot of practical parts in between.
Thank you very much. Thank you very much, Dr. Rama. That's very, very interesting talk and very stimulating. I mean, I really enjoy it and I learned a lot from it. And I'm sure my colleagues and the residents also learned a lot from it. Very, very interesting talk. I don't know if there is anyone have any question to Dr. Rama for the
والله ما
attendance.
بخوف أسأله لو عندك كويس ولا أسأله باخدكم بالراحة.
I have one
Just
question,
one-
Dr. Rama, if you...
Yeah, go ahead.
طيب في الأمفيتامين
Can you
Dr.
sorry? Can
Rama-
you just say your name and so that
yes,
you,
sure.
Yeah. Sorry.
Yeah,
Otherwise,
I'm Hussein, BGY2.
Okay.
Just a question. Where do we label the methylphenidate for the patient who take ADHD? يعني قصدي it's going to go on the same cycle of the psychostimulants, but then will be an addiction issue for the patients. زي الريتالين مثلا.
Again, it depends. خليني أكون صريحة. It depends on how are we giving it and when, and we know that most of our ADHD patients are vulnerable for addiction. That doesn't mean that you don't give them the medication. It depends on the dose. And again, using 1 gram of amphetamine on daily basis is completely different than giving a patient their medication dose, which is actually regulated in a different way. So no, it goes in the same pattern. Yes, the methylphenidate does the same. If you give it to the patient, it blocks, it helps the stimulation of the dopamine. It blocks the reuptake. It does the same thing, but the doses that you're giving predict if the patient will be addicted on it or not. So that's why we say when you see that your patient is exceeding it, and the pattern of giving the Ritalin is also one of the kind of risky things. So it is usually advised to give the long acting, well-regulated like Concerta, الحاجات دي. And if your patient react on non-stimulants, that's a better option. General psychiatry can also add to that, but we usually, you think from that perspective, liability, age of start of giving the medication, impact on that patient. Is he vulnerable with his history for psychosis for other things? Is there any behavior which makes you question giving them the Ritalin? We have a lot of ADHD patients who became addict using the Ritalin in different patterns. حتى يعني وصلوا لإنه يفتحوا الكبسولة حقتها and they يعني sniff it. So it's a smart thing. If you can treat them with non-stimulants, that would be good. If not, use the long-acting like Concerta and other things that. And there's a lot of new long-actings now in the market, so you can use.
Thank you.
Thank you. Thank you. Actually, I have a question, Dr. Rama, just for the sake of the training and just for my own sake also. So just recap what you're saying earlier, is that any drugs work directly with dopamine can be linked to psychosis more than other drugs, like, for example, the amphetamine and things like that, more than opiates. Is that, yeah. So what about the, how do you explain the nicotine? Because it also works directly on the dopamine, but is not associated with psychosis.
And mainly because the dopamine gush of nicotine is lower than the glutamate extract of nicotine. So if you look at everything coming from nicotine, dopamine, nicotine is not a big gusher of dopamine, but it gives the balance that it impacts glutamate level, it impacts other levels of other neurotransmitters to give the reward. But that makes it also more difficult to stop. عشان كده شايف الناس انت he says, yeah, stopping with quotation بتاع stopping with smoking is very easy. I've been doing it several times. So it is the repetition of due of that. But the balance is there, I think. Yeah, you never see patients using nicotine only becoming psychotic. So.
And if you do compare with non-addictive brain and the brain, that mice figure you just mentioned in your presentation, the difference between the non-addicted brain and the brain, I mean, after what can we say, like, I'm not sure if you can say cure, but if we say treatment of addiction, is addicted brain goes back to be like the non-addicted brain in terms of structure, or there will be changes? That
most of the literature ولا الشغل بتاع الناي ده كله اللي فيه looking at the brain and the fMRIs and everything that they've been doing says that it never goes to balance back. It never goes to what it was, mainly because it has changed the hemostasis level. Normally البرين كان فيه ماشيين the level above of allostasis, and going back في a lot of cellular damage at cellular level and level of the what you call it delta phos مش عارفه شنو الحاجات basic of the cells دي بيكون حصل فيها let's say great damage. فلما ترجع تاني it never goes back to the يعني السلام عليكم جميلة لذيذة زي ما كانت أول. You are always less than, but it doesn't mean that there is no recovery, because يعني بيشوفوا at least الكلام اللي تقرأوا فيه إنه في recovery for example working memory. There is a recovery in printing of learning. في كم حاجة بس basic كل الحاجات ما بترجع زي ما كانت ever never. And it depends on the severity also of the addiction itself and on periods of use.
Very nice. That's very interesting. Any guys, I think we come to the end of the time, but is anyone have any question before we?
أنا عندي question here. Actually, it's more about the potential بتاعت medications. يعني حتى ما هنا street drugs. The potential بتاعت medication to cause addictions. And this is exactly I came across this one time. How the half-life and the area under the curve of the medication itself, how the medication work, can make the medication effect, or can make you more like prone to develop addiction. يعني الكلام ده جاء في الكلام في mainly في البنزوديazepines على why مثلا البرازولام Xanax is more likely to cause addiction in comparison مثلا diazepam ولا مثلا lorazepam.
It's I don't يعني ما عايزة أفتي شديد، لكن there were two articles يعني وقعوا في سكتي في إنه one of the problems of the short, the medication with short half-life, that their cycle of reward gush leads to the quicker addictive process. إنه أنت عندك peaks and downs every time, which بيعمل حاجة زي شنو بقولوا على drug enforcer cues إنه this is nicer, this is better. That's one aspect. بس كمان impact of the short working medication on the production of dopamine is higher لأنه بيشتغلوا more on the direct actions أكثر من بقول على شنو اللفة اللي بالجنب دي. That's one of the problems. But yeah, I don't know. That's what I came through يعني along, but I'm not sure is that the complete explanation for what you're saying. نفس الحاجة دي بتلقاها في use of Seroquel, for example. عنده نفس impact, especially for patients who have disturbance in the level of their neurotransmitters, يعني اللي عندهم manic episodes or اللي عندهم borderline dynamics, اللي هم بيكون عندهم kind of zigzag neurotransmitters. So when you give them that type of medication, their liability to get addicted is a big word, but at least to have withdrawal, higher withdrawal symptoms from it is there. So I don't know if I answered your question, but that most.
Thank you.
Hopefully.
Yeah, thank you very much. I'm just checking for the chat. Is there anyone writing any question? I don't think so. Oh, that's fine. Okay, guys, is anyone else? Is any last question? No. Okay.
شكرا لكم Dr. عبد العظيم. This is not my first time to work with the Sudanese.
Oh, sorry. Yeah. Somebody
No. I'm
corrected me.
really proud of being able to do that.